Welcome to the Head and Neck Oncology Journal Club, and today we're covering a landmark Phase 3 trial that could change how we treat high-risk resected head and neck cancer. The study is NIVO-POSTOP, just published in The Lancet, and it addresses a clinical problem that's been stuck for over 20 years. Here's the issue. For patients with locally advanced head and neck squamous cell carcinoma who undergo surgery and have high-risk features like extracapsular extension or positive margins, the standard treatment has been postoperative radiation with concurrent cisplatin. This was established back in 2004, but despite this aggressive approach, 40 to 45% of patients still relapse within 2 years. That's a massive unmet need. NIVO-POSTOP asked a simple question: can we do better by adding immunotherapy? The trial randomized 666 patients across 82 sites in 6 European countries. All had high-risk resected disease. The control arm received standard chemoradiation, 66 gray with cisplatin every 3 weeks for 3 cycles. The experimental arm added nivolumab, 1 dose before radiation, 3 doses during radiation, then 6 doses as maintenance afterward. The population was predominantly oral cavity cancer at 58%, with hypopharynx, larynx, and oropharynx making up the rest. Importantly, 95% were HPV negative and all had at least one high-risk pathologic feature. Now for the results. At a median follow-up of 30 months, disease-free survival was significantly improved with nivolumab. The 3-year DFS was 63% versus 52.5%. That's a hazard ratio of 0.76 with a p-value of 0.034. What's particularly interesting is where the benefit came from. It was driven primarily by reduced locoregional relapses with a hazard ratio of 0.63. Distant metastasis rates were similar between arms. Here's a critical finding that differs from the metastatic setting. PDL1 status did not predict benefit. The hazard ratio was similar whether CPS was less than 1, between 1 and 19, or 20 and above. This suggests that in the postoperative minimal disease setting, the immunobiology may be fundamentally different from bulky unresected tumors. What about toxicity? Grade 3 treatment-related adverse events were slightly higher with nivolumab at 73 versus 68%. Grade 4 events were 10 versus 5%. But here's the key point. There was no increase in treatment-related deaths. 2 deaths occurred in each arm. The most common nivolumab-related side effects were thyroid disorders, fatigue, and diarrhea, all manageable. Now let's put this in context. NIVO-POSTOP is the second positive trial for perioperative immunotherapy this year. Keynote 689 showed benefit with pembrolizumab in the neoadjuvant plus adjuvant setting. Both trials succeeded where multiple others failed in unresected disease, including Keynote 412, Javelin Head and Neck 100, and Invoke 010. Why did these postoperative trials work? The hypothesis is that minimal residual disease after surgery creates a fundamentally different immune environment. Without bulky tumor mass suppressing immunity, checkpoint inhibitors may be more effective at clearing microscopic disease. Here's the bottom line. NIVO-POSTOP establishes that adjuvant nivolumab added to standard chemoradiotherapy significantly improves disease-free survival in high-risk resected head and neck cancer. The magnitude of benefit, a hazard ratio of 0.76 and a 10 percentage point improvement at 3 years, is comparable to the original benefit of adding cisplatin to radiation 2 decades ago. For your practice, this can be proposed as a new standard of care. PDL1 testing is not required for selection, and the benefit comes primarily from better locoregional control with manageable toxicity. After 20 years of therapeutic stagnation, we finally have progress. That's your 5-minute evidence update. Subscribe for weekly episodes, and I'll see you next time on the Head and Neck Oncology Journal Club.